Dear colleagues and friends, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem from the Erasmus Medical Center here in Rotterdam, and together with my good friend and colleague Joost Daemen, we will preview what is coming as late-breaking trials at the upcoming ESC Congress in Amsterdam 2023. And maybe, Joost, we can start off with a two-piece on ECMO, because two important trials will be presented on ECMO. First is the ECLS-SHOCK trial by Holger Thiele, and Holger always comes up with important randomized controlled trials, and this time he is looking at 420 patients with cardiogenic shock in the context of ACS. Patients will be randomized to PCI in combination with ECLS, thus ECMO, versus PCI without ECMO. And then the primary endpoint is 30-day mortality. Important exclusion criteria are patients who required CPR for at least 45 minutes, also mechanical complications of infarctions like ventricular septal ruptures and mitral regurgitation are exclusions, and also severe peripheral arterial disease. I think this is an important study.
Absolutely.
But you can always ask yourself, okay, but why would ECMO favor patients with an ACS? Because you will increase the afterload, you will increase myocardial oxygen consumption. At the same time, these patients are in shock. They do require some kind of mechanical support. So it's going to be an interesting one. And I'm not convinced yet that this will be a positive trial because of the potential detrimental effects of ECMO and the afterload increase, but also typically in those trials, out-of-hospital cardiac arrest is a nasty thing, and it will affect your primary outcome of mortality. Obviously, if you have more patients with an out-of-hospital cardiac arrest, I think by default your 30-day mortality will be high, and how difficult that will be to affect it with mechanical circulatory support, that is one. The other one I think is important is also the timing of the insertion of your ECMO. Will you wait longer? Then probably patients will be on a higher dose of vasopressors, for instance. That might also affect the outcome. I'm very interested. Also, it is important when you put a patient on ECMO is, okay, what is the venting strategy? Will you do a default venting strategy? And what would that be? Would that be an Impella, or would that be a balloon pump? Very interesting questions. This is one of the potential highlights of of ESC this year.
Absolutely, yeah, a lot of interesting stuff. But again, it will be a complex study to digest because of all the parameters that will affect the endpoint. As you say, the timing will be of critical importance, the venting strategy, and also looking at a previous study from the Czech Republic, 60-70% event rates at 30 days. So there is potential statistically, but we need to see what Holger Thiele will show us.
Yeah, and by the way, this Czech trial was a negative study, right? So there was no benefit
with half the sample size.
Yes, and but still there was no signal even of benefit for patients when they were put on ECMO. Okay, we'll see. But another important study, and the second piece of the two-piece, if you will, on ECMO is early unload study, also a German trial. Approximately 200 patients with cardiogenic shock will be randomized to either the use of ECMO in combination with a venting strategy, a default venting strategy of Impella, versus ECMO as a standalone, and then only venting when it's clinically indicated. The primary endpoint is again the death, all-cause death at 30 days. Exclusion criteria more or less similar. There is an exclusion for peripheral arterial disease, but again, out-of-hospital cardiac arrest was allowed, and if patients were in shock for more than 12 hours, they were also included for the study. Again, it's going to be a very interesting trial. Again, you want to know how many patients had an out-of-hospital cardiac arrest, what was the vasopressor dose before entering the study. But I expect a negative study, and even I'm curious whether we will not see a signal of harm, because these patients will get two large bore arterial cannulas. One of the 19 French of the ECMO, and the other one is a 14 French of the Impella. So will there be a bleeding or a vascular complication issue? That's an open question. Let's see whether that becomes a positive study. And at the same time, I think this is also a missed opportunity, because we're all familiar with using venting strategies, but the discussion on whether a balloon pump would suffice or whether you immediately need to escalate to an Impella, that hasn't been solved in my opinion.
Absolutely.
So ideally, we would have had a 3-arm study. One venting strategy with Impella, the other one with venting with a balloon pump, and then a control arm without any venting. Let's see what's coming up there. Then there is another study in patients who had an out-of-hospital cardiac arrest. Tiffany Patterson will present the ARREST trial. This is a study from the UK, a very ambitious project, where they were aiming for 860 patients with an out-of-hospital cardiac arrest and return of spontaneous circulation. And then patients were randomized to either transfer to the closest by hospital or transfer to a hospital with all the facilities, including perfusion to put patients on ECLS and so on. The primary endpoint, again, death at 30 days. This is another study where I have a hard time accepting that this will become a positive trial. Again, mortality rate of these patients is high by default, and I'm even wondering whether they will be able to collect 860 patients in this trial. So we'll see what's happening there.
Conceptually, a big trial, interesting. But to me, what is the greatest challenge of this trial is that it actually tries to address 2 questions, right? One is early ECMO, and the other one is logistical influences of transferring patients to specialty sites for shock versus local sites. So that to me is always at least scientifically a challenge.
Yeah, and you raise an important matter, right? So the logistics around an ECLS program and what is the time delay in a receiving hospital between accepting the patients and then having ECLS in the patients. So the time to circulatory support. The 2 things will for sure
interact and will impact the outcome in whatever way.
Let's switch gears now and talk about intravascular imaging and coronary intervention.
Yeah, so for those who are a fan of intravascular imaging and physiology, ESC this year will be a must-go meeting. There is a wealth of trials that will be presented on intracoronary imaging and physiology. Some have even called it the OCT firestorm, which is upcoming. I'm not sure, but what we will do is to give you a little bit of a glimpse into what is to be expected in Amsterdam this year in terms of imaging and physiology. First trial that will be presented is the GUIDE DES trial, a randomized controlled trial designed to assess whether clinical outcomes will differ between a QCA-guided PCI strategy versus a IVUS-guided PCI-based strategy in patients undergoing PCI with drug-eluting stents. Again, a Korean trial, 1,500 patients that can be enrolled with either stable angina or acute coronary syndrome. Primary endpoint target lesion failure at 1 year. The trial has a non-inferiority design. Investigators estimated a 8% target lesion failure rate. With a non-inferiority margin of 3.5%. So with these numbers, I think it's very likely that the investigators will demonstrate non-inferiority. That said, the trial focuses a little bit on the concept that IVUS is still underused, is perceived to be more expensive, and needs specific expertise, whereas QCA could theoretically be more readily available and is for sure a lot cheaper. That said, I don't think the trial will make a big difference into our guidelines and clinical practice. I mean, we have a strong body of evidence supporting that IVUS-guided PCI is better, irrespective of the use of post-dilatation or not, as we've learned 2 years ago. And with that, I do believe in the concept of QCA, but I'm not sure it will beat IVUS.
And what about the non-inferiority design? Is this what we are needing? Don't we need a superiority study? Because how do you want to change the practice here?
Well, the concept of the investigators is that we know IVUS-guided PCI is better than eyeballing. Right? That has always been the competitor. In this case, the investigators argue that with QCA you can be more precise in stent sizing, so you tackle half of the potential IVUS benefit. For post-PCI, you obviously can use QCA to measure a minimal lumen diameter. Please recall, this is a 2D technology, if used in a 2D way, which will be the case in this trial. So there you miss a lot of the opportunity of the post-PCI optimization, addressing underexpansion and so on. So from that perspective, I do believe you can make a small benefit with QCA, but it will not be on par with IVUS. But in a trial like this, remember Renovate. Target lesion failure rate in Renovate was 8% at 3 years. Here they estimated in the IVUS arm it would be 8% in 1 year, which is a very ambitious event rate. So I would guess that the final event rates in the trial will be lower, and with that a non-inferiority margin of 3.5% will be difficult to make.
Because they're not targeting the more complex lesions, they're targeting any lesion.
Any. Yes, stable and unstable. So this is not complex PCI. It's a more common design, so to say.
And so I also want to bring this to the audience that we are conducting and finalizing the inclusions of the CHIP IVUS randomized control trial, where we are randomizing patients to either IVUS-guided or angio-guided PCI of complex coronary lesions, and that hopefully will be presented next year. All right, ILUMIEN IV.
ILUMIEN IV is
highly anticipated.
Highly anticipated. So the big randomized control trial comparing OCT-guided PCI versus angiography-based PCI in a large sample of 3,500 or up to 3,500 patients that will be enrolled in 80 sites across the globe. Enrollment has been ongoing since 2018, trying to address a primary endpoint, co-primary endpoint, I should say, of post-PCI minimal stent area and target vessel failure rate at 2 years. So the trial to me is very important because following 8 to 9 randomized controlled trials showing the superiority of IVUS, the evidence for OCT as a single entity remains a little bit behind. And with this trial has the potential to saddle the role of OCT as the equivalent option to IVUS for patients in this trial specifically with either diabetes or more complex anatomy. So that is something, this is not real world, it's a trial in which patients are selected based on a high risk for repeat procedures, being either having diabetes or complex lesions, long lesions, bifurcation, CTOs, etc.
And that makes a lot of sense, I think, because that is where you can
that's where you expect the benefit from the imaging. That is absolutely true. That's also why all the first IVUS trials were also performed on more complex anatomical patient subsets. So I look out for a very interesting presentation in which I will also have a specific eye on the impact of the specific stent sizing protocol. So that in ILUMIEN was so to say groundbreaking. You need to stent based on the median, no longer on the lumen. Specific guidelines for stent optimization, looking at the edges, positioning distal stents, post-dilatation quite aggressively and so on. And it will be interesting to see how that will impact also complication rates, procedure times, etc.
Well, but there is an elephant in the room here, and that is how many OCT runs will you do in one patient, in one single patient? Because mind you, every OCT run will require contrast.
Absolutely.
And so from a contrast exposure, radiation exposure, that's also something that we have to bear in mind when we are using OCT, and that might or may not be a potential benefit of IVUS over OCT. But there are also studies comparing IVUS and OCT that will be presented. Right?
Yeah. We'll get to that in a second. Second big trial on OCT-guided PCI is October. Also a trial that started in 2018 comparing OCT-guided PCI versus angiography-guided PCI in patients with bifurcation lesions. Trial run by Niels Holm, 1,200 patients, 60 sites across Europe, presenting either with stable angina or a stabilized acute coronary syndrome. Multiple bifurcation stenting strategies were allowed, so provisional only, but then two-stent strategy was allowed. But it was very important that in the OCT-guided arm, runs needed to be performed to check the position of the wire, to verify that you took the distal strut in order to rewire the bifurcation, look for amellar position, stent positioning, etc. Trial will have a 2-year endpoint of cardiac death, target lesion MI, and target lesion revascularization. So to me, an interesting trial. I'm not so sure this trial per definition will be positive. What I do think is that this trial in 1,200 patients will teach us a lot on the impact of specific types of bifurcation stenting strategies, because my personal belief is that it's not about the technique you choose, so it's destenting, culotte, it's DK crush or whatsoever. It's more about the fact that if you use two stents, you need to make sure that the stents are well opposed, you didn't miss the ostium, and so on and so on. And that's where imaging in general can make a huge difference, and that's where I hope we will learn a lot from October with respect to bifurcation stenting strategies and so on.
But if they're looking for that kind of granularity, for instance, also looking at the strut that you're using to cross into the side branch, how many OCT runs are they looking at?
But that's exactly the elephant in the room, as you would say, for this trial, because it is to be expected in what percentage of patients the operators actually reacted. First, recognized the fact that the wire was in the wrong strut. Second, how oftentimes they reacted to the wire being in the wrong strut and rewiring taking a more distal strut. How often that impacted the post-dilatation strategy, the effect of the post-dilatation. So there's a lot of factors that need to be taken into account when interpreting the results of this trial. Yeah. But that said, I think it has the potential to be from a mechanistic perspective, for sure, very interesting. And one thing we didn't mention, in how much percent of the cases in the OCT arm, a OCT of the side branch actually allowed to withdraw from a two-stent strategy, and that is also something that could result perhaps even less two stents in the OCT arm. But that's all guessing. We'll see.
And you know what also will drive the clinical reproducibility and the adoption is the number of runs per patient, then the overall volume, and also the procedure duration. Because if it adds half an hour to the procedure, I think we will struggle to get this adopted in our practice. Yeah, but again, we also were looking at comparing OCT with IVUS.
Yeah, so comparing OCT versus IVUS, so that's in every IVUS course we do a hot topic. When do I use IVUS? When do I use OCT? In that perspective, again, the Koreans designed the OCTIVUS trial, which is the fourth big trial to be expected on imaging at the ESC. 2,000 patients randomized 1-to-1 to either IVUS or OCT-guided PCI. Eligibility with stable angina but also ACS. The investigators hypothesized that there was a non-inferiority between both strategy in terms of a primary endpoint of a target vessel failure at 1 year. Again, a sample size, assuming 8%, in this case a non-inferiority margin of 3.1%. So again, same story as with guide DAS. I expect no significant difference. But recall Renovate, a trial in which imaging was compared to angio, 75% IVUS used, 25% OCT. No significant heterogeneity, but results of potential differences between IVUS and OCT have not been released yet. In this trial, we will see if there is a difference. We learned from Renovate that there was a slightly higher percentage of optimal PCI in the OCT-guided arm, but again, OCT definitions versus IVUS definitions. So comparing apples versus oranges, I do believe both technologies have their merits, but I don't expect huge differences between the two in this trial, but we'll see.
Exciting, and also in terms of patient selection, what would happen if, what is for instance their exclusion criteria in terms of kidney disease? Yeah. What is their cutoff? Because that also obviously will determine your choice in clinical practice. Absolutely. Whether you would aim for an IVUS or an OCT, and also what kind of lesions are we talking about? Is it an ostial left main? Is it an ostial right? That also determines the choice of technique that you want to use. So I think this is going to be a very intriguing study, and I think collectively all these trials on intravascular imaging will become highly relevant for our practice. But there's also physiology-guided PCI. Yeah,
so this is the final trial that we would like to highlight in this topic. So FIRE is a randomized controlled trial comparing physiology-guided PCI to angio-guided PCI in elderly patients presenting with STEMI. Simone Biscaglia will present the results. Patients needed to be 75 years or older, and the hypothesis is that complete revascularization is likely more beneficial in younger patients as compared to older patients. Please recall, both in complete versus in BioVasc, there was no heterogeneity with the cutoff at 65. This trial looks at the cutoff of 75. 1,400 patients, primary endpoint, patient-oriented, including stroke at 1 year. Interesting concept, we'll see. My issue with this trial, that is again that we are mixing different concepts. First, complete revasc versus staged or cuprate only. Second, the use of physiology is considered best in class for STEMI patients versus angio. Well, that has not been proven yet. So a lot of items that may impact the results in this trial, plus the fact, again, also a little bit like in BioVasc, is that we're mixing STEMI and non-STEMI. So we'll see, but I think definitely something to look out for.
Yeah, my bet is that it's going to be a negative study. So
I tend to agree, but
let's see.
we'll see. Yeah, and then finally, following all these data, Greg Stone will present a meta-analysis on all IVUS and OCT trials. So obviously with ILUMIEN, with OCTIVUS, a lot of additional data to add. We'll see. Usually there's a reason that people pool data and want to strengthen the message or even put the specific message more in perspective. We'll see. August 27, early in the morning, the results will be presented. And also interesting final trial I wanted to highlight is a meta-analysis of defined flare and IFR sweetheart at 5 years. You would wonder, why is this important? Well, the reason this could be interesting is that there was a potential, or not a potential, there was a significant increased mortality risk in defined flare at 5 years in favor of the FFR arm. So higher mortality rates in the IFR arm, which was not statistically proven in sweetheart. In this case, the results will be pooled, so hopefully that will put the mortality issue a little bit in perspective.
Okay, good. Then let's switch gears again, and now a heart failure study, the HeartFit, a randomized controlled trial, is looking at the impact of IV iron therapy in over 3,000 patients with HFrEF and obviously symptoms. The strategy is quite interesting. So basically, patients will receive 2 doses of IV iron with 1 week in between, and then after 6 months, the therapy can be repeated depending on the iron status of the patient. So patients need to have iron deficiency, but not anemic. They should not be anemic. Well, I'm a big believer in IV iron therapy in the context of heart failure and definitely in HFrEF patients. But obviously we had the Ironman trial that was presented last year at AHA. This trial from the UK, smaller trial, only 1,100 patients, failed its primary composite endpoint of cardiovascular death and heart failure hospitalizations. But it just failed its endpoint, and that also had something to do with the COVID-19 pandemic. So my gut feeling tells me that this is going to become a clearly positive trial, and that this trial hopefully will help shape the guidelines further. Yeah. Then I also would like to highlight STOP-DAP3. This is a Japanese trial that is looking at the value of further trimming down the antithrombotic regime after PCI. Patients will be randomized to either prasugrel monotherapy for 1 month and then switching after 1 month to clopidogrel monotherapy versus a control arm of DAPT, prasugrel and aspirin for 1 month, and then followed by aspirin monotherapy for the remainder of the year. 6,000 patients will be randomized, and these are high bleeding risk patients. So I still have an issue with this focus on high bleeding risk patients, because as far as I know, there are no hard penalties for reducing the antithrombotic regimes. If you look at the high bleeding risk trials that we've seen so far, there is no penalty of more thromboembolic events. So why would we not look into these trimmed down regimes in all comers? Anyway, this is the topic of another randomized controlled trial that is currently ongoing also here in Rotterdam with Valeria Paradias, where we are looking into, this is the Compare STEMI 1 trial, where patients are randomized after 1 month to either DAPT for 1 month and then monotherapy, or DAPT for 1 year. So this is something similar, but that is more an all-comers STEMI patient population. The safety outcome is major bleeding at 1 month, and the cardiovascular outcome at 1 month is a composite of cardiovascular death, MI, stroke, and definite strand thrombosis. So do we really need DAPT from the get-go? I'm also a believer that we might be able to drop the aspirin, and this will be the first trial to look into that question. Secondary endpoints will go out to 1 year. It is a Japanese trial, so the extrapolation to the Western population may be limited, but I think this set the stage for another larger trial also in a Western community.
Yeah, a lot of trials on the topic in the past years, different mixtures of different regimes of combining clopi with aspirin, prasugrel versus aspirin, aspirin only, clopi only, prasugrel only, tika only. There's numerous variants on the topic. As you say, Asian study. different bleeding profiles. These patients typically have a higher risk of stroke, lower risk of MI as compared to the Western population, which is conversely bubble C. I think it's a big trial with, which will have some impact.
Yeah, and another interesting study from our perspective at least is the Multi-Stars AMI trial. Barbara Steli will present this trial on 840 patients with STEMI and multivessel coronary artery disease. Patients will be randomized to an ad hoc complete revascularization or a staged complete revascularization strategy. And obviously you will remind the BioVas trial that we presented and published earlier this year in the Lancet. That was a randomized controlled study basically looking at the exact same treatment strategy, but then in the context of ACS, combining patients with STEMI and non-STEMI, and in that particular trial, 40% of the patients had a STEMI. So we were talking about 660 patients with STEMI in BioVas. BioVas was not powered for the single indication of STEMI. This Multi-Stars AMI trial, a little bit larger trial, 840 only STEMI patients. We'll see how it will compare to BioVas, but we found that a ad hoc complete revascularization reduced MI and unplanned revascularization rate versus a staged procedure. Let's see what the Multi-Stars AMI trial will show.
I foresee another meta-analysis.
that might definitely be the case, and if this trial also points in that same direction, that also might help further shape the guidelines, right? Okay, and then to finalize the Notion trial, this is a trial on TAVI, at least one trial on TAVI that we wanted to highlight. Notion is obviously a study that has been going on for quite some time, and we will now see, I guess, the 10-year and final follow-up of this patient population. These were supposedly low-risk patients, but still the mean age at study entry was 79 years old. Their STS score was 3.0. So I would call this a more intermediate risk patient population, and patients were randomized to either TAVI with a early generation core valve device or surgery. We already know that at 8 years there was no difference whatsoever in terms of mortality and stroke or MI between the two treatment strategies, but there was a clear superiority of TAVI versus surgery in terms of structural valve degeneration. It didn't translate into more events, but that might change at 10 years. So at one point, you might expect that structural valve degeneration will also result in bioprosthetic valve failure and re-interventions. It wasn't clear at 8 years, but maybe we will start to see a signal at 10 years. And then this becomes very interesting because this trial is underpowered. But if this will hint towards better durability in favor of TAVI over surgery, then this will be ground changing. But obviously we will also need the 10-year outcomes of the low-risk trials that will add many more patients at 10 years with 10-year follow-up echoes coming from the Partner 3 and the Evolute low risk. But at least this trial will set the stage.
Yep.
All right, with that, I think we highlighted the most interesting trials from our point of view. Will you be there in Amsterdam?
Absolutely.
Me too. So we hope to see you there. And if you would not attend, no worries. We will come with a wrap-up after the event. Thank you for joining us. Bye.
Bye-bye.